thank you to all our guests that are here today. So without further ado.
So I'm going to start. Good afternoon. This is, as Troy said, the first of Hot Topics in Global Health. We do have an outside speaker, Dr. Fred Finkelstein from Yale, but I'm going to spend the first half hour, as promised, giving you a primer in really who are the players in global health. It took me about 20 years to figure out who the real players are in global health. So I'm going to share this perspective with you. But before I do that, I do want to talk to you a little bit about what Hot Topics and what my goal is. This is the first in the series, what my goal is for Hot Topics. And what we'll be doing. We'll be doing this once a month. This will be hopefully attracting residents from many subspecialties. I've closed it to only 5 medical students because we had over 25 that signed up for it. But just to give you an idea of who some of our speakers are, we have one of our future speakers in the room, Dr. Rajaya Bhatniji is going to be talking to us on November 2nd on global health financing and understanding where the money goes. He did his PhD at Oxford, was it, in this area? So I'm very much looking forward, having read that fabulous Lancet article that he did. On December 17th, we have a historian from the Hoover Institute, Bert Patnaud, who will be talking to us about the history of humanitarian aid and disaster relief. On January 4th, the CEO and former president of the Global Fund for Women will be talking to us about global women's issues in health. On February 1st, I asked my deputy director, Amy Lockwood, who ran her own NGO in micronutrients, to talk to us about addressing global micronutrient nutrition. On March 7th, Jack Colford, who really has one of the largest Gates grants on water and sanitation, will be coming from Berkeley to talk to us about water and sanitation in global health. On April 4th, I asked Freya Spielberg, who I'm trying to recruit here, from RTI to talk to us about how mobile health technology can make a village doctor great. And on May 2nd, Robert Siegel, who some of you may know, if you've spent time at Stanford, will be talking to us about pandemics. And on June 6th, I asked Shakti Srivastava of the surgical department to talk to us about simulation and how we can actually work with modes of simulation in global health. So I just wanted to give you a flavor of what the upcoming lectures are going to be, so you can get an idea of what I'm trying to do on these hot topics. So today, the goal of my primer is really to review the key world players in global health, review the architecture of the U.S. global health programs, and understand the strengths and weaknesses of assistance in global health. So there are 3 major, and I'm sorry, I'm going to go from very simple to very complicated. So bear with me while I do some of these definitions. There are 3 major types of global players that have the money. And when you think about it, they're the multilaterals. These are organizations involving 3 or more governments, allowing for efficient pooling of resources. So some examples of these are all the UN agencies. And I'm going to go a little bit more into depth, but I want to start with definitions when I talk to you about multilateral, bilaterals, and NGOs. Bilaterals, the term bilaterals are used as really one government giving money to another government. So USAID would be U.S. giving to whoever they choose to give it to, and it's usually politically motivated. DFID is the USAID equivalent in UK, CETA in Canada. So each of the individual countries, especially of the G8, that's the global 8 countries, and again, if I use a terminology that you don't understand, ask me or ask Rajai, who probably knows more about it than I do, of the global 8. But NGOs, non-governmental organizations, are organizations that do not form, they're not part of a government, and they're not usually for-profit, although some of them are. They're usually nonprofits, and I'll talk to you a little bit. Those are the ones that you probably know the most about: Oxfam and Face AIDS and Save the Children. So that I just wanted to make sure that we're all talking on the same terminology about multilateral, bilaterals, and NGOs. So who are the key stakeholders in global health? When you think about who really cares about global health, it is obviously these multilaterals and bilaterals that are giving out the money, so they have an interest. And some other examples of multilaterals, the Global Fund, the UN agencies. Everybody knows what Gavi is? The Global Alliance for Vaccine Initiative. Stop TB and roll back malaria. So those are the multilateral examples. Bilaterals we already talked about. Another stakeholder that we don't often think about, but it's really becoming a big player, is the private sector. And especially in Silicon Valley here, it's amazing to me how many people arrive in my office from the biotech companies that are going into global health. So this is becoming a big player. The pharmaceutical and diagnostic companies. You all know about Bill and Melinda Gates, but now a lot of the smaller companies. Look at Cepheid across the street. That's going to change the world in tuberculosis with Gene Expert. So some of the smaller foundations are also really becoming big stakeholders in global health. Academia and research organizations, I have no illusions that I was recruited to Stanford because of me. It's because academia, there was no dean of global health until 2 years ago. Academia is becoming very interested in building up global health programs. I'm on the board of consortium of universities doing global health. We have 72 now universities with 390 programs and 92 countries. So you can see that universities are really bursting into the scene with global health. And then there are research institutions like the Carnegie Institute, Rockefeller Institute, all of which are globalizing more and becoming more and more interested in health problems in global health. And think tanks. I never kind of understood what a think tank was, but it's actually these, they're not-for-profit usually, that people sit around and they get contracts to think about problems. And so the Rand Corporation, I would consider a think tank, to give you an example, and very active in the area of global health. Then there's civil society that's become a big stakeholder. And I place in that NGOs and community-based organization. And then individuals themselves. It's amazing to me also how many individuals have arrived in my office in this area, interested in global health. Not only affected individuals, but family members and community members. So when you think about global health and the arena and the playground of global health, try to think about these key stakeholders. So what are some of the milestones of the path to global health? And these are big milestones. And you can't get any bigger than Jenner, who discovered the smallpox eradication. There's nothing really bigger than the smallpox eradication campaign. And in 1796, Jenner discovered the way to prevent smallpox, but it wasn't until 1976 that we actually eradicated this virus. And hopefully in the next couple of years, we'll eradicate polio. Some other big milestones is the formation of the International Red Cross, which was in 1863. In 1913, Rockefeller Foundation played a huge role. They decided that their foundation was going to actually try to work with malaria, yellow fever, and hookworm. They actually did major eradication of hookworm. In 1945, the World Bank was formed, and UN and UNICEF followed right after World War II. And the World Health Organization really didn't start until 1948. So these are some of the milestones that I would say. The Millennium Development Goals at the Millennium, and in 2002, the Global Fund was started. Now, these Millennium Goals have sort of been driving, and I know probably everybody in this room knows about the Millennium Goals. And there are really 8 goals that were set up in the year 2000 at the World Summit at the UN. Even though I'm going to argue, this is the Barry rule, I think this is like completely bogus that there are only 3 that are health sector related. Because when you think about it, okay, so reduce child mortality, improve maternal health, and combat HIV and AIDS are the 3. But in actuality, promoting gender equality and empowering women is going to help health. Achieving universal primary education. Everybody knows that 1 year of education in a mother's life increases child survival. So all those other goals, whether it be eradicating extreme poverty and hunger, are going to affect health. So it's not really a 3 goal, Millennium Goal. It's really all of the 8. And in 2005, these 8 goals were broken up into 16 targets. And you can see the 16 targets. It's probably hard. Can you even see them in the back of the room at all? But basically, and what I love this is the kind of, this is the pattern. Each of these are the 16, 1 through 16, and it just gives you an idea of the progress data for each of these goals. So if you look at improving the life of, well, halting, if you count across, well, first just look at the red. The reds are where there's been no progress, and you can see in sub-Saharan Africa up to goal 10, halting and reversing spread of HIV, AIDS, you can see they've made very little progress towards any of these goals. Whereas the greens show you Latin America and the Caribbean had made a lot of progress in sanitation and slum dwelling. But believe me, Brazil still has its favelas that it can talk about in pretty much Latin America, but they are improving it and trying to improving the lives of slum dwellers. So it's a kind of a nice way to look at the progress of the Millennium Goals over the first 5 years. We haven't seen the next 5 years. We're all waiting to see that chart. So I do want to spend a little bit of time, because we do have an outside speaker, so I'm going to speak for half of this hour, and then Fred Finkelstein is going to talk for the next half hour. But I do want to spend a little bit of time talking about how the U.S. Funding for global health programs has really played a role in global health. And you can see, I have to say, I have nothing really good to say about George Bush, except for the fact that he did more for global health in really his years of presidency than probably any other program. And you can see that the amount of global health funding that went into the PEPFAR, the Presidential Fund for AIDS, and also the Millennium Challenge Corporation and Rollback Malaria, I'll show you some of these, were quite significant. But if you look at the funding of the U.S. Global Health Initiative as a share of the federal budget requests, we're really very teeny. I mean, it looks like everybody gets crazy that we're giving $10.52 billion to global health. But if you look at what percentage of the federal budget we are, it's only 0.3%, as people would say decimal, I learned a new term, decimal dust, because I have to go up on the hill. But we're considered decimal dust. And you can see that even our foreign aid is, we're 1.3% of our federal budget. It's pretty small. If you look, the thing about the Global Health Initiative in the United States, it's a very vertical program. And when I use the word vertical versus horizontal, it's not about, horizontal is health strengthening capacity, whereas vertical is very directed towards TB, HIV, malaria, one disease. So you can see that many of these budgets are very vertically allocated. So that you see, except for the Global Fund, which the Global Fund, they give $1 billion of the 10.5, and that's a very health system strengthening. But you'll see maternal child health, malaria, reproductive health, or neglected tropical diseases. Very vertical way of giving out money rather than a health system strengthening. Don't freak out about this chart. It took me about an hour to figure out this chart and how I would present this to you. But that big budget of $10.52 billion is spread across many places, many players. So the Global Health Initiative reports to the White House, but the majority of the money goes to state and to USAID. And under state, most of that money goes to PEPFAR, but there are smaller programs like Water for the Poor and the Avian Influenza Group. Under USAID, the President's Malaria Initiative and Neglected Tropical Diseases comes in. So you can see it's spread out. Under HHS, that's where we have CDC, NIH, and the FDA, and HRSA. So that you can see that that Global Health Initiative money is spread across many parts of the global health. Even things like labor and commerce and homeland security get money for global health. And they have little initiatives. DOD has many initiatives in global health. So that you can see, and these are the keys, that many of these are departments, independent agencies, a department operating unit, or a multi-agency initiative. So you can imagine how confusing this is when you look at this chart as to who's running global health in the United States. And I can tell you there's a lot of turf wars. I mean, you just have to go to the Hill and hear a little bit of these turf wars. That it's constant turf wars. And I thought this was kind of an interesting pie chart to mirror what I just told you, is that if you look at that, this is the FY 2008, this is the only one I could find. But if you look at who gets the majority of that money, and if you think of how we use our money for global health, we're using it for diplomacy. So a lot of what state and USAID does is what they call this smart diplomacy. That's the word that's used in the government. And state as well. But you can see NIH, look at CDC, very small pie. You know, I always used to think CDC was it, you know, doing most of the Global Health Initiative, but actually it's not. The Peace Corps gets a very teeny bit. We're working on, if anyone went to my malaria grand rounds, you know that I've been working on a medical arm of the Peace Corps, and that's going to be even a smaller part. Hopefully we'll get out of PEPFAR money. But you can see how the money is divided up. I'm going to spend a few seconds talking to you about UN alphabet soup, because it, again, took me many years to understand UN alphabet soup, which is basically, and this is a timeline of, these are the major programs that really have global health initiatives, and the big players in global health, whether it's the Food and Agriculture Organization or UNESCO, which is the United Nations Educational, Scientific, and Cultural Organization. Everybody knows what UNICEF is, right? The Children's Educational Emergency Fund. World Health Organization, the Refugee UN High Commission of Refugee Services, the World Food Program, and then the United Nations Development Program. But those are the big players in global health in the UN. Again, you think there are turf wars in the US government? We're minor league compared to the turf wars that happen in the UN. I wanted to highlight a few words about the World Health Organization, who's now the Director General is Margaret Chan. There are 195 country members, of which there's a 34 rotating member executive board. The WHO provides its missions to provide training, guidelines, and committees to address epidemics of infectious and non-communicable diseases, and it supports development of vaccines, diagnostic, and drugs. Personally, I put this in, what I think they've done the best at is EPI, the Expanded Program of Immunization, but they recently stepped into epidemics, and I think many of you have seen what's happened when they went into SARS, very effective bringing countries together and quarantining, and avian flu, and influenza in general. They do a very good job, even though they get criticized a lot. It's one country, one vote, and they're really stretched thin. And this was a shocker. Their entire budget is a budget of Stanford Hospital. I mean, so they have a very small budget. We always think that WHO can give us money. I can't tell you how many medical students I have in my office. I want to work for WHO. Well, fine, but you're not going to have much of an impact because they don't have a lot of money. It's a very cumbersome organization. It's in Geneva and has 6 regional offices. It's a very weak constituency of ministries of health and has a tremendous amount of political pressures. So you can imagine what World Health Organization, but it is our organization globally that we depend upon for health. Am I going the wrong way? I'm going the wrong way. Other multilateral organizations that have much bigger budgets, the Global Fund to Fight AIDS, TB, and Malaria, Gavi, which Seth Berkley now just took over, which just got an unbelievable amount of money. They did a big fundraising, and the World Bank. Those are the big players for multilaterals that have the money. And I just want to highlight a few words on the Global Fund. I think for those of you who had the pleasure of seeing, I had Richard Feacham speak last year or a couple of years ago, and he used to run the Global Fund, actually was the founder of the Global Fund. It's really a financing mechanism. It's not an implementing mechanism. So it's not something you can apply to for money, but basically countries can apply for money. And the neat thing about the Global Fund is you come up with a project, and as long as you have full transparency and you're not in their corruption budget and you're evaluated well they will give you money. So it evaluates proposals through an independent review process, and it's based on technical merit. To date, it's committed $22 billion in 150 countries over 10 rounds of prevention, treatment, and care programs. And they're given to recipients in 2 phases over a period of 5 years. And you can sometimes get it reapplied. And again, you have to, in order to get a reapplication, you have to have a performance-based funding and evaluation. And lastly, I'm going to end with NGOs. And what are NGOs? These are non-government, there are thousands of these. They're really. And these have different functions. They can be foundations that donate finances. They can be implementing organizations that actually go out there and implement, malaria control. Or they can be a civil society program and actually advocate for communities. So that's kind of the end of the discussion that I wanted to talk to you about. And I will focus a little bit on Save the Children, whose mission was to inspire breakthroughs in the way the world treats. This is just an example of an NGO, which shows child protection, education, health, nutrition, and HIV and AIDS. But I'm going to end and let our outside speaker, so that's kind of a primer on all the programs in global health and who the major players are and where the money is. Before I transition, I want to just say that the future of, you could see how confusing that was. The coordination of efforts is going to be a nightmare. Just looking at, let's just go back to that chart of the U.S. You can imagine if that's the chart of who the big player is in global health, how many agencies are involved. You can imagine how hard it's going to be to sustain that and keep up the funding. And then I think many of us are thinking about donor and developing country roles. We're changing now. In this economy, the big player, China, we don't know where China's going to play a role. China now absolutely gives very little money out. I think we need to think about emerging diseases. We see when things like Ebola or H1N1 hits, how it stretches things. When you have a World Health Organization with the budget of 1 hospital, you can see how hard that's going to be to organize member nations. I think we need to think more about horizontal versus vertical approaches because we really need to have donor countries or host countries be able to strengthen their health capacity rather than to work on one disease. And then lastly I'm going to end is can you, as individual practitioners, actually play a role? And that's why I asked one of my colleagues from Yale to come here and speak. And so I'd like to introduce Fred Finkelstein, who is a clinical professor at Yale, but also the chair of the Dialysis Committee in the International Society of Nephrology and the international liaison on the Committee of International Society of Peritoneal Dialysis. And I asked him if he could speak how he, as an individual, and he really is one of my heroes, with what he's been able to do within the Society of Nephrology and with his life as a super subspecialist, how you can actually make an impact on global health. So Fred, let's transition over to your slides. Troy, can you help us transition? While Fred comes up here, are there questions about what I presented? Oh, there must be some questions. There are so many out there. If there's not, I'll feel really good. Go ahead.
Well, this might be a little bit off topic, but there was I'm curious what your comments would be on a recent high-level meeting of the UN for non-communicable diseases. If you think that'll have an impact, or
well, so tell me, how much publicity did that get? Did they come out with a statement? Many of us are waiting.
Yeah. Okay.
I think it got a little bit overshadowed by the Palestinian vote, which happened simultaneously in the UN. But
so I think it has had a large impact.
Okay, go ahead.
At least as a nephrologist speaking, it's had a large impact.
Good.
So maybe we'll talk about that. Okay. So I'm going to talk about chronic kidney disease and dialysis in the developing world. And I think the work I've done is interesting perhaps from a specialist point of view. And maybe a question I would ask you as medical residents, if you go into a non-infectious disease-related specialty, what role can you play in global health? And I'm going to try to suggest to you that you can have some large impact.
Wait 1 second. We're taking this. Sorry.
And are a lot of opportunities, but there are also a lot of challenges, and that's what I'm going to talk about. So I've been involved in sort of international health for over 30 years. And initially when I started really just doing general medical work, and I would go to a developing country, do some general medical care, but really try to be involved in teaching and developing programs. In the last sort of 6 to 8 years, I've shifted to almost exclusively doing nephrology, and I'll try to show you why that is. Nephrology is extremely well positioned to get involved in the global health scene, and it's because of what I'm showing here. The major international organizations all have a commitment to developing nephrology programs in underserved areas. And these include the ISN, the ISPD, and the Pediatric Nephrology Group. So all international groups have committed funds to support programs, and the programs they've developed are primarily educational programs or programs to support research. So the sister city programs, continuing educational program, scholarships, travel grants, ambassador programs, but they're all focused on providing education, training support, and advice to helping countries develop strategies to how to deal with nephrological problems. So I'm going to start by giving you a couple, just a case example and sort of a small research project I did back in the 80s that sort of got me very interested in this problem. So in '78, I was working in Afghanistan for a couple of months, sort of just before the Russians invaded. And I was there really doing general medical teaching in a hospital in Kabul, a Jim Marietta hospital, a teaching hospital. And a 17-year-old single woman had gotten impregnated in a remote village. She had an abortion performed in the village. 2 days later, she developed fever, chills, stopped making urine. Her uncle, who was in the military, was able to get her out of the village, traveled by camel for a couple days, by car for a couple days, shows up in Kabul. On arrival, she had fever, chills, no urine output. There were no supplies at the hospital. Her uncle goes down to the bazaar, buys antibiotics, she's treated. She's still making no urine after 8 days. Now, there's no laboratory support in the hospital, but anyone would realize if the girl's not dialyzed, she's going to die. So we looked through supplies that were donated by Care Medico, found the peritoneal dialysis catheter. So I went down to the pharmacy and convinced them to make sort of a modified peritoneal dialysis solution. We placed the PD catheter. She was dialyzed for 48 hours. She becomes afebrile. She starts to pee. She walks out of the hospital and goes home. Sort of a very simple example of how using a little bit of technical expertise in a complex case, you basically save this girl's life. And the question then is, could this be reproduced elsewhere? Second lesson came when I was in Vanuatu. Vanuatu is in the South Pacific. It's a Melanesian country sort of over here between Fiji and New Guinea. And I was working there again doing general medical work. And I was amazed in the 4 weeks I was there were just an incredible number of cases of nephrotic syndrome that were completely unexplained. So how you would approach it became something that I was very interested in. What was the differential diagnosis? Could you do empiric treatment of nephrotic syndrome? But to do that, you had to know the spectrum of disease. And the only way to know that would be to do a kidney biopsy. So we found some of these old TrueCut needles, which are the old kidney biopsy needles. And in 4 weeks I was there, I did 18 kidney biopsies, which is incredible in a general medical service to see that much nephrotic syndrome. I taught one of the doctors there how to do additional biopsies. We sent all the material back to Yale, processed it, and the differential diagnosis is sort of shown over here. It's completely different than you'd see in a Western country. So coming up with an empiric regimen to treat nephrotic syndrome made no sense without understanding what the spectrum of disease was. And that's what we learned here. So let me take a step back now and say, given other health problems in developing countries, is kidney disease a relevant topic? And the answer to that is clearly yes, as I look at it. So you can look at it from two perspectives. One is from acute kidney injury perspective. Acute dialysis saves lives. It's easy, it's not expensive to develop, and I'll show you this in just a minute. And importantly, you can save young people's lives. People who would die if they didn't have dialysis for acute kidney injury, you can save their lives very cheaply. I'm going to show you that in just a minute, how you do that. And from the chronic kidney disease perspective, the thing I've learned now in the last several years, that even in the poorest countries, there are people who have money, who have resources, and want to be treated. You have to help the country develop a rational way of dealing with this problem. A decision may be not to dialyze them at all and let them all die, but that may not be the right thing to do, as I'm going to try to show you a little bit later on. I think you need to work with countries to develop what you think are rational programs for this. But importantly, as developing countries mature, they are going to have to address the problems of diabetes, chronic kidney disease, and hypertension. Governments need to develop strategies to develop an approach
whatever it may be, to dealing with chronic kidney disease and end-stage renal disease. And as we talked about before, the WHO initiative came out on non-communicable diseases. There was no emphasis on renal disease, no talk about renal disease. And the nephrology community actually lobbied WHO to change that unsuccessfully, so chronic kidney disease was not mentioned. But in any case, a shifting focus to non-communicable diseases is the part that I think is actually very interesting. So let's go back. Back in a few years ago, in 2007 actually, we were approached by the Kenya Renal Association to have a conference on the status of kidney disease in the eastern part of Africa. And we set this up jointly with the ISN and the ISPD. And the meeting was actually really very interesting. So there were doctors there from a variety of countries in East Africa. But importantly, the Minister of Health from Kenya and the Sudan came to the meeting as well. And what we talked about was the relevance of nephrology, which was based on the observations that the economic status of these countries was improving. Other basic healthcare issues were being addressed, but nobody was paying attention to the metabolic disorders, diabetes, hypertension, and progressive kidney disease. So these diseases, which are so prevalent in the West, everyone knows are going to increase dramatically, as will the incidence of chronic kidney disease. And the countries knew they needed to develop strategies to deal with this problem. And that's where the ISN, the ISPD, and the pediatric group could come in, where they could help them develop rational programs for dealing with these problems. Now, as you probably know, the incidence of end-stage renal disease is threefold higher in African Americans than Caucasians. And it's an interesting issue, and I don't know if you followed the work recently on this APOL1 gene, which has been described in African Americans in the US as a gene which is very closely segregates with progressive renal failure in a variety of diseases. For example, focal segmental glomerulosclerosis, diabetes, ischemic renal disease. And the APOL1 gene protects against trypanosomiasis. So it's sort of similar to sickle cell disease in a way. You're having a gene which protects against infectious-related disease, but causes a whole host of other problems. So this is really sort of an interesting issue. And what's shown here is the incidence of end-stage renal disease in African Americans, which is this line over here, the top line. And this is the line in Caucasians here. And this is the prevalent rates. And you can see there's about a threefold higher rate in African Americans. So what most people think is that as African countries develop, the incidence of chronic kidney disease is going to increase dramatically. And the association of chronic kidney disease with cardiovascular disease and hypertension, I think everyone's familiar with. And this is going to have an enormous impact on the healthcare in these countries. So there has to be strategies and ways of dealing with this. So now to think, if we're all going to think about how the nephrologist or nephrology community can play a role in the developing world, we need to understand the needs and the resources that are available, understand the social, religious, historical, economic, and cultural context of the country which you're dealing with, understand the current political realities, and understand the current nephrological programs that are in these countries. So I don't know if people are familiar with this. This is from the U.S. Renal Data Systems database that tracks the incidence and prevalence of renal disease in the U.S. but around the world. And this is from the most recent report in 2010. And not to belabor this, but if we look on the left side, which is the prevalent rates, the prevalence rates are highest in Taiwan and Japan and the United States. But the rates are running about 2,000 to 2,200 patients per million population per year. You get down here to the bottom, you're looking at Bangladesh and the Philippines, which have, about 20 patients per million population per year. So there's almost very little end-stage renal disease care going on. But this is what's going on in Africa. And this is in 2008, but actually the numbers really haven't changed very much. There are about 23 countries in Africa where there are no dialysis services at all, which means that patients who develop acute kidney injury are going to die. Patients with chronic kidney injury die as well, but importantly, patients with acute kidney injury die. So this is really very interesting, and there's been actually not much change in this over the last several years. So one of the questions we thought about is, could we work to develop programs to manage patients with acute kidney injury in a systematic basis? And we decided to do this in Tanzania. I'll come back in a second why we did this. So in Tanzania, there was no end-stage renal disease care offered, with the exception of a small for-profit dialysis unit in Dar es Salaam. And this was run by a partially trained nephrologist And they were charging patients somewhere at $150 to $170 per treatment. And it was really set up simply to make money from those people who had financial resources. There were no acute dialysis services available anywhere in the country. Anyone who had acute kidney injury died. So we were able to get a grant from the Sustainable Kidney Foundation. There's a philanthropic group based in New York. Money was given to them actually by a family, a wealthy family with a strong history of polycystic kidney disease. And the grant was to develop programs for acute kidney injury in African countries. So we then looked and decided to do this up in Moshi at Kilimanjaro Christian Medical Center, which is shown here on the bottom. And the reason we decided to do this was interesting. At one of the nephrology conferences, we ran into a nephrologist from Canada, Karen Yates, who works in Kingston, Ontario at Queen's College. And she's an amazing woman. She has actually set up a women's shelter and healthcare center in Moshi. And because of her presence there, she spent 3 months a year in Moshi, we decided this would be a wonderful opportunity to set up a program for acute kidney injury because she would be there and could help supervise the program. And she had residents and nephrology fellows actually from Queen's College in Kingston who would go periodically for visits so we could oversee and supervise the program. So the model we set up was shown here. 2 doctors and 2 nurses were sent to Brazil to be trained on acute peritoneal dialysis techniques. Now, why Brazil? The reason they went to Brazil is because people without licenses could practice medicine in Brazil. So they could be taught to put in catheters, and nurses could actually take care of patients. And actually, Brazil has a very strong peritoneal dialysis program, and I'll come back to that a little bit later on. So they went to Brazil for about 2 months and were trained basically on how to do peritoneal dialysis. They were trained how to put in catheters. Nurses were trained how to do the dialysis. They learned the basic principles of peritoneal dialysis. So these were, again, 2 residents, a pediatric and an adult resident, and 2 nurses from the floor who were sent over to be trained. Supplies were donated by the Sustainable Kidney Foundation, and the supervision then was provided by this group from Kingston, Ontario, by our group in New Haven, and by a pediatric nephrology group in Chapel Hill. And the model we set up that when these guys were back, if they were seeing patients, they would send text messages, emails. We'd give advice over the phone on how to manage things. And the program actually has done very well, which I'll show you in just a second. But the key elements that we learned here were providing adequate training, which we were able to do in Brazil, setting up a program to monitor the outcomes and make sure we're doing it right, look at the costs, look at the sustainability, and provide the ongoing supervision. So the results. So we set up a database, which these guys sort of tracked. There were 20 patients dialyzed over the past year. 16 patients left the hospital. We had decided in advance that if anyone did not recover kidney function within 30 days, they would be sent home to die because there was no means of supporting the program. So as I'm sure you know, 98% of people with acute kidney injury are going to recover within 30 days. We had 2 patients died in the hospital, which is actually very low because the mortality for acute kidney injury with people requiring dialysis in most centers is around 50%. So these patients probably weren't as sick, but still it was an acceptable kind of result. And we were actually very pleased with this. Now what about the costs? So we had estimated in advance that we projected most people would need dialysis for about 10 days, that they would do a modified CAPD technique, which would be 5 exchanges a day for 10 days. We're able to get solutions in at $5 a bag, so it's going to cost $250 per treatment. $100 for the catheter and ancillary supplies. It's about $350 per life saved, is the way we looked at this. And our estimates were right pretty much, that the average duration of dialysis was about 10 days in this series. And our goal was to reduce the cost of the thing to $3 a bag, so the cost would be $250 per saved life. It seems to me that's a bargain. You know, it's relatively cheap. And most of the patients were actually young. The question then was, how do you convert this to a sustainable program? And we looked at this carefully, and the model we came up with was this, that we'd ask the hospital to set up a special fund which would be contributed to by patients, families, villages, donors. The funds would need to be sequestered to repurchase supplies. We try to convert the program to a sustainable program in 3 years, and our estimates were that the cost of the solutions was going to drop over time. And we decided we needed to support the program with additional training. So one of the initial residents we trained has gotten an ISN fellowship and is going to South Africa for more training. And we've trained 2 additional residents on site to support the program. So the program is really running, and it's running very well. We have 4 residents now actually helping do the dialysis, one resident doing an ISN fellowship. We have funds to support the program. We have these sequestered funds set up. So what else has happened in Tanzania? Well, amazingly enough, this past year, the government authorized insurance payment for end-stage renal disease care for all government employees. Now, this is sort of astounding. What is Tanzania doing agreeing to pay for end-stage renal disease care? It makes no sense, but a financial sense. But that's, in fact, what they've done. I'm going to show you a little bit later other countries which have done the same thing. So the problem is if they're doing that, either you just let them do it or you decide you're going to work with them to make a program that runs well. And at our last conference in Moshi, which was in March of this year, we met with the government, actually, and discussed strategies, expanding PD, trying to drive down the costs, trying to set up additional hemodialysis facilities, but doing them in a cost-effective way, and then consider developing a transplant program, which may seem crazy, but I'll come back to that, why that's important a little bit later. We tried to look at the same thing in Uganda, and Uganda is a program that actually Michele helped set up as part of the Johnson & Johnson program, where a lot of sort of residents go to work for a couple months. But we got a Ugandan physician to spend a year at Yale as an ISN fellow, and he's now back in Kampala organizing a nephrology curriculum for the medical school. And our plan was to run an ISN, ISPD, and IPNA-sponsored nephrology course in Kampala in January, but it turns out it may or may not happen. We're not sure about that yet. But basically, we're trying to reproduce the model we've used in Tanzania for treatment for AKI. So right now in Tanzania, there's no treatment for AKI. There are 2 small private dialysis facilities that charge tremendous amounts of money that really, but is not helpful in supporting patients with acute kidney injury. But the barriers are we cannot get the hospital or government to agree to let the solutions in the country for reasons that are just amazing. We're dealing with this for 9 months now, and we can't get them to agree to do it. So these are the challenges in setting up these sorts of programs. I'll give you another example in Cambodia. Cambodia has no dialysis for acute kidney injury. Anyone who gets AKI in the country dies, basically. There are 2 small private hemodialysis units in Phnom Penh that, again, charge us $150 a treatment, so it just caters to the wealthy, but they will not provide dialysis for people with AKI. So it turns out Baxter donated some peritoneal dialysis solution to AmeriCares, which is a philanthropic group in Stanford, Connecticut, who works with the Sihanouk Hospital. Sihanouk Hospital is a hospital in Phnom Penh that is supported by wealthy Japanese donors. So we decided to set up a PD program sort of along the lines we did in Tanzania. We sent our doctor and nurse to Hyderabad in India to get trained, and India works the same way Brazil, anyone can work. So these guys were trained, and they went back, and this is the Sihanouk Hospital shown on the right. 6 patients were dialyzed, 5 left the hospital, 1 patient died. And the plans we had set up to make it a sustainable model were, because there are people in Cambodia who have funds, that we would try to set up a for-profit arm of the hospital to create a sustainable AKI program that used the profits from running that small dialysis unit to support the program for AKI in the hospital. But the challenge is, again, the Japanese donors withdrew almost all their money after the tsunami hit Japan. The government became very concerned over this 1 patient who died in the hospital, and the program really has been put on hold since then. But just a few months ago, I got a call from people from the University of Washington who have a very large global health program and are actually very heavily invested in Cambodia. And they actually approached us about restarting the peritoneal dialysis program in government-sponsored hospitals. So that's being explored now. There's a Hong Kong nephrologist who's living in Cambodia. So in a sense, it's a really global sort of team that helps develop these programs. So we're looking at restarting this in Cambodia now. Ethiopia is another country we're interested in working in. So Ethiopia has 70 million people. There's no dialysis anywhere in the country. It's really quite amazing. Nothing. Anyone with acute kidney injury dies. There's a small private dialysis unit in Addis Ababa, again charging an outrageous amount of money. There's a nephrologist in Addis who's been trained as an ISN fellow in South Africa. There are well-trained nurses there. We have funding set up to set up the program in Ethiopia through the Sustainable Kidney Foundation. You know, we visited, everything is set to go, but we cannot get, in addition, there's a very active exchange program with the University of Toronto, this global health program. And the University of Toronto's take on Ethiopia was to set up specialty training programs. It's actually very interesting. So they've set up residencies in anesthesia and gastroenterology now. And we've discussed with them setting up a nephrology training program in Addis Ababa. And we're looking into doing that now. But the barriers are we can't get the government to let us bring in the supplies into the country. It's absolutely amazing. This has gone on for a year now. And we can't even get the people in the hospital to pressure the government to let the supplies in. So we're sort of sort of stymied. Program is basically set to go. If we got the program up and running, we'd probably start to develop a nephrology training program. We can't seem to do it. So what about end-stage renal disease care? Just a few minutes, and I'll go through this quickly. Again, the issue really is, should you be spending your money doing end-stage renal disease care? What are the resources, the fiscal responsibility, getting training, setting up quality standards, tracking outcomes? And importantly, if you are going to do this, you need to have international support and international dialogue. If you're going to do it, it's got to be done right. You can't do it in a half-baked sort of way. So looking at this, the most interesting program that we found is the one that's running in Sudan. So Sudan was the host for the African nephrology meetings called the AFRAN meetings in 2007. We're in Khartoum. Sudan it's interesting, has 46 million people. There are actually 20 nephrologists. They have almost 3,000 hemodialysis patients, 100 peritoneal dialysis patients. They have a nephrology training program that's very well established. Dialysis is completely funded by the government. They have set up a very detailed registry of all patients starting dialysis, and they track outcomes very carefully. Now, you could ask, what's the government doing spending the money on this, given the issues that are going on in Sudan? The program has been set up, so that's what it is. And if it is set up, it seems to me our obligation is to work with them if we can to make sure it's done in as an effective manner as possible. Now, the reason Sudan has done this, it's very interesting. However bad Sudan is now, was much worse in the 80s and 90s. So Sudan's medical education is based on the UK model, and the medical school is actually very good in Khartoum. And in the 80s and 90s, most doctors who were trained left the country. And they sort of went to Saudi, to UAE, or back to the UK. And as the economics changed in Sudan in the late 90s, in the early part of the century, these guys all went back to Sudan, actually, and have set up these programs. So this is from our visit there in 2007, and this is their peritoneal dialysis program. And this guy in the middle here, Hassan Abu Aisha, became health minister in Sudan, actually, which was sort of very interesting. He's the guy who really set up all the dialysis programs. And the tall guy standing next to him went through the medical schools in Khartoum, passed his ECF&G exams, did a residency in a small hospital in Pennsylvania, and is now finishing a 2-year fellowship in Denver, and is going back to Khartoum at the end of this year. And what's interesting about what they've done, they set up a detailed registry. They published a paper on this in 2007, going through all their outcomes. They've really done it right, and this, to me, is the model that should be reproduced if the decision is made to start end-stage renal disease care. Senegal is another example. So Senegal is where the AFRAN meetings were held in 2011, February of this year. Senegal is interesting. So there's a population of 13 million. Most of it is rural. The average public expenditure on health is $23 per capita per year. They have 230 prevalent dialysis patients as of the end of last year, treated with hemodialysis, and 30 with peritoneal dialysis, all of them in Dakar. There are no dialysis services outside Dakar. And patients who have wanted transplants have been sent to North Africa because it's French-speaking West Africa and their connections are with the North African part. But what's happened here? The government in 2010 decided to underwrite the costs of almost all the costs of dialysis programs in Senegal. Does that make any sense? So Michelle's shaking her head. No, it makes no sense. But the reality is, Michele, that's what's happened. And that's, if you actually go to Senegal, there's really a wide economic split, maybe not that different than in the US now, from very wealthy people to people who have no funds, and the people with funds insist on getting the care which they know is available outside of the country. So if the country is going to provide that care, what should the response be to do that? Either you say, we're not going to support it because it's crazy, or you decide you'll work with the country to develop most rational programs you can. So we looked at it and decided the latter was the approach we'd use. So at this meeting, we decided that developing a transplant program in Senegal made a lot of sense, because this could be the focal transplant program for all of French West Africa, which is in fact what's happening now. The program is working with Oxford, which has done this in a variety of other countries around the world. So you use cheap medications, generic cyclosporin, azathioprine, prednisone, generic medications, not the optimal regimens, but regimens which work very well. And this will be the focal point, presumably, of the French West African thing. And then we worked through the ISPD, to develop a peritoneal dialysis database with this group to make sure that outcomes were going to be tracked and monitored in a reasonable fashion, so that the job they're doing is really adequate. So in fact, there are now well-organized databases for at least peritoneal dialysis, which I'm particularly interested in a variety of countries now, where it's clear that 1- and 2-year patient survival rates and technique survival rates are very similar to what you see in the West. Peritonitis rates are higher. than they are in the West. It's 1 in 20 patient months, whereas in most countries in the West, it's 1 in 24 to 1 in 36 patient months. And I just show you this from the Brazilian Registry on Peritoneal Dialysis, looking at outcomes, and this is stratified by educational level. That education has no impact. Illiterate people do as well as people with college educations. That's in essence what this shows. So the educational background is not important for outcomes of home peritoneal dialysis. So lastly is I want to conclude with what another choice is deciding you're going to ration dialysis. And that's the plan that South Africa made. So in South Africa, they've made the decision that only patients who are eligible for kidney transplant are offered dialysis at no or low cost. Funding is covered by the government. If you're not a transplant candidate, you will not be offered dialysis services. And less than half of the people who are referred for dialysis actually get dialysis, and those who don't are sent home to die. So that's the decision the South African government has made to push transplant as a more cost-effective way to deal with end-stage renal disease care. So lastly, I conclude, I started with the panel on the left, so let me end with the panel on the right. As I look at nephrology in the developing world, there's exciting opportunities in terms of understanding the spectrum of disease and developing treatment strategies and healthcare policies. The international nephrology community provides strong support, so it's in some ways it's a very nice specialty to be working in. But the challenges are difficult and frustrating, but they really do need to be overcome. And I think there's a lot of work going on to try to overcome these barriers now. So perhaps this is an example of how a specialty can get involved in the global health scene and play an important role in sort of rational decisions that healthcare is really sort of organized. Thanks.
Back to your question about non-communicable
Right.
diseases and the fact that now greater than 50% of the deaths in the developing world are now coming from non-communicable diseases. We're going to have to deal with this. And I have to say, Fred is one of my heroes because he has literally put this on the map in the nephrology subspecialty. And it just shows you how one individual can actually make a difference, and one individual in a subspecialty can make a difference. And I'd like you to sort of reflect upon that whole mishmash of global health players with all those billions of dollars. And Fred's doing this on, what's your budget?
No, it's tiny. So I guess the one thing you left out were the international specialty organizations around the world. I think they're not as well organized as nephrology for providing support and funding. The total budget is $100,000.
So I just thought it was a nice balance to what I presented earlier. So open for discussion and questions. Are there any budding nephrologists here? Oh my goodness.
Yeah.
So you said you were communicating with the high-level meeting, like the groups try to get nephrology in that declaration. Was that for AKI or chronic kidney disease, obstructive hypertension?
It's sort of a combination of the two. If you go back, I assume you're all familiar with the fact that because of chronic kidney disease, it increases cardiovascular risk. And that screening tool is a huge interest now in screening chronic kidney disease. So, people are now very interested in screening populations in the developing world for what the incidence of CKD is, and then developing rational strategies to deal with that, to cut down the cardiovascular risk, to slow progression of kidney disease, to decrease the number of people progressing to end-stage disease. That's really what the main initiative was in that regard. But as I look at it, you want to do that, but you've got to have rational ways of dealing with, it's inexcusable to not have programs for AKI set up. You can do it for PD very cheaply, and it works very well. We've clearly shown that. You have to have a strategy for dealing with end-stage renal disease. You can do what South Africa does, decide you're going to ration care. That's fine, it's okay. But for Tanzania to decide they're going to pay for everybody in the government who works for the government, or for Senegal, they're going to say they pay for everybody, is crazy without having a rational way of dealing with this. That's the part that's problematic. But who should be working with them to come up with rational solutions? It seems to me that's the role these international societies should do. And that's what they're trying to do, really. Yeah.
You alluded in your first case to the fact that laboratory studies weren't really available. In these settings, what kind of monitoring do you do for these patients? Is it mostly just initial, trying to get their dialysis set up, and then after that, they can run their own, or do you?
Okay, so we monitored hyperkalemia with EKGs. That was the one in Afghanistan. So you're able to do it that way. It's not really the right way to do it. So if you have funding to support it with the Sustainable Kidney Foundation, we set up an autoanalyzer, actually an inexpensive one, in Tanzania to monitor laboratory studies. So we do that. it was amazing. Let me go back. It's an interesting example. So at KCMC, the Kilimanjaro Christian Medical Center, there's a lab in the hospital that is completely inaccurate. So we went to, Duke is running a whole AIDS program in KCMC, and they set up their own own service inside the hospital where they have their own laboratory support. So we went to them and said, we're developing this program, could you run the labs for us? They're going to charge us $5 of potassium, $5 for a creatinine. We said, well, this is crazy. We don't have the money to do this. We want the money for supplies. They would not run the labs for us without paying this incredible amount of money. It was like ludicrous. So we actually wound up buying our own inexpensive used autoanalyzer. We had someone go over and set it up in Tanzania. But it's an example of how the global community needs to work together, needs to look at what programs are important and cooperate together and develop these programs. Duke's response was moronic.
We'll have to get that back to the Duke people.
Yeah, we talked to them, but you hooked us up with them, right? And it was really very disturbing, actually.
I was curious about the AIDS certifications because it seems like there's barely anything done except being left to die. I don't know what in your opinion is the ideal way to do it. But it seems like separating from is nothing.
So it's really a challenging problem. Sudan is actually very wealthy because of the oil. It was wealthy because of the oil. With the split in the country now, the northern part of Sudan is going to be really in trouble. So, what should they do? Should they put resources to support end-stage renal disease care? That's really the challenge. The answer seems clear to me. It should be no. One way you might do it is decide you would provide care for patients or individuals who have financial resources to do that, and then use some of that money to support programs for acute kidney injury. That's the model we tried to set up in Cambodia. That makes a lot of sense to me. The risk is seen, I didn't talk about what goes on in India. India is a good example now of how not to set things up. So in India, the government insurance companies pay for almost nothing. And you pretty much go to a family and say, you've got to pay for each treatment. Now the cost is relatively low, but the cost by Indian standards is substantial. So the family starts selling off whatever possessions they have to cover the dialysis treatments. They start with 3 days a week, they go down to twice a week, then go down to once a week because they're running out of money. Then the family goes broke and the guy dies, or whoever it is dies, and the family's lost everything they have. That's a clear example of how not to set it up. So I think you need to sit with people in the beginning and say, listen, do you have the resources to sustain it over time? Can we organize a transplant at a reasonable time frame so you don't lose all your funds? So the model in Tanzania was not to do that. We decided after 30 days, if you don't recover, you're dead. That's it. I mean, nothing you can do. There's no way to support it.
We should end because it's 1 o'clock. Thank you, everybody, for the first hot topics. We'll see you in a month.
Thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.